So, Mr. Chairman, thank you very much for that kind introduction, and Shobha Mishra Ghosh, many thanks indeed to you and to your colleagues at FICCI for inviting me to talk. Yeah, it's good. Okay, so I need to introduce myself a little bit and explain to you what I want to talk about and why Shobha invited me to talk. So, I'm a cardiologist. I work at these hospitals in West London, Ealing Hospital, a small district general hospital in West London, St Mary's Hospital and the Hammersmith Hospital. And I've been working as a cardiologist for about 20-25 years now. And what's distinctive about the population that I serve in West London is its very high cultural, ethnic, social diversity. And specifically, the population of Ealing Hospital are now 50% South Asian heritage. So half the people I look after are actually people who were born and bred in Delhi. So I share a very similar set of problems to my colleagues at Fortis, Max, etc., in that I have to look after a very high burden of South Asians with an excess, very high rates of type 2 diabetes and cardiovascular disease that are a considerable challenge to healthcare provision. So just to flesh out how much of a burden diabetes and cardiovascular disease are, here are the usual horrendous facts and figures from the World Health Organization and other major bodies. So cardiovascular disease, for example, remains and will remain the world's leading cause of death for at least the next 50 years. Currently, 18 million people die a year from cardiovascular disease. That's 30% of global cardiovascular disease mortality. And the majority of those deaths are not occurring in the UK or in Europe. The majority of those deaths are actually occurring in the low and the middle income countries, and in particular in India. Diabetes is a huge problem. It's a huge problem globally, but particularly a huge problem for the population of India. The generic statement goes that 1 in 4 Indians has diabetes, and 1 in 4 diabetics globally is an Indian. A huge burden of disease. And the numbers are getting worse. So it's estimated that 10 years back there were 40-odd million people with diabetes in India, but that within the next 10-20 years that will have doubled to almost 70 million. Diabetes accounts for perhaps 1 million deaths per year in India. So this is a huge problem. And both these epidemics of cardiovascular disease and diabetes are in turn driven by this horrendous global epidemic that we see of obesity, with an estimate that by the year around now, 2015, almost 2 billion people globally are affected by overweight and obesity. So when faced with these numbers, cardiovascular disease, #1 cause of death, doubling of diabetes globally, doubling of obesity globally, there's sometimes a real risk of feeling overwhelmed and there's nothing we can do. This is a disaster, we should just bury our heads in the sand, we're done for, we should just pack our bags and go home. And I'm here to challenge that concept, because I'm going to tell you that it doesn't need to be that way. It absolutely does not need to be that way. So here, in complete contrast to everything I've said about a global epidemic of cardiovascular and metabolic disease, here are the cardiovascular mortality rates in the UK for the last 30 years. Since 1970, so 45 years, there's been a progressive year-on-year fall in cardiovascular disease mortality rates, so that now, honestly, they're closing down cardiac services in hospitals. They're closing down cardiac cath labs because they're no longer fully occupied. This is not just true in the UK, it's also true in other major Western European countries, and also in the United States. All of these developed countries have been able to deliver a 70% reduction in cardiovascular mortality that's gone against the global trend. So how has this been achieved? What are the ingredients to success? The ingredients to success that the Indian healthcare system needs to learn from and implement and take forward vigorously and productively in the coming years. So the ingredients to success that I identify are sixfold. We need to understand the causes of cardiovascular and metabolic disease. We need to reduce exposure in the population. We need to educate our populace about what is driving disease. We need to identify high-risk individuals. We need to implement effective treatment to those high-risk individuals. And we need to monitor the performance of the healthcare system to make sure that it's delivering to the standards expected. So I'm going to talk through some of those points. Understanding the causes of disease. Well, actually, in 2017, we're pretty well informed about what drives cardiovascular disease. There are now, it's quite clear, 8 or 9 major cardiovascular risk factors: diabetes, hypertension, cigarette smoking, being overweight, being physically inactive, poor, unfavorable diet, etc., etc. We've known about these things for decades. And if you want to know whether they really account for the burden of disease in the population, there's a beautiful study done by a chap called Salim Yousaf, who's based in McMaster in Canada, where he looked at the contribution of these classic risk factors to cardiovascular disease in the world's global populations. And I quote word for word his conclusion that traditional cardiovascular risk factors comprising abnormal lipids, cigarette smoking, diabetes, obesity, diet, physical inactivity account for most of the risk of myocardial infarction worldwide, in both sexes, at all ages, and in all regions. Specifically, these cardiovascular risk factors account for 90% of myocardial infarction. 8 or 9 risk factors, treatable, reversible risk factors, account for 90% of disease. So we have a good handle upon the causes of disease. And here's a nice illustration of the importance of the problem. It's what's your likelihood of having cardiovascular disease according to the number of classic risk factors you have. If you've got 4 or more risk factors, you're highly likely to have the disease, 20%. But the important thing to note is if you have no risk factors, you have effectively 0 risk of developing cardiovascular disease. We understand the causes of disease pretty much. These are what they are. So this knowledge underpins the World Health Organization vision that we should be addressing these known cardiovascular risk factors more vigorously. And the World Health Organization, in partnership with the world's governmental organizations, has set out the so-called 25 by 25 targets. That is, that by the year 2025, there should be a 25% reduction in mortality from cardiovascular disease, diabetes, and cancer, the non-communicable diseases. A 25% reduction by the year 2025 in the world's global populations. It's only 10 years away, and that we can achieve this through very simple public health measures, such as reducing alcohol, improving physical activity, reducing salt intake, reducing tobacco consumption, better management of blood pressure, better management of diabetes and obesity. So, component number 1, understand the disease. Component number 2, educate and protect your populace. So, we understand the importance of obesity. We understand that there are adverse lifestyle behaviours that drive the epidemic of obesity. Access to sugary drinks, fatty foods, high salt intake foods. We need to help educate our populace. We need to help regulate. We need better regulation of food standards so that the provision of the environmental provisions, cigarette smoking, physical activity, and diet are better managed. And although there's often an ambivalence to say, how can we change people's attitudes towards cigarette smoking? How can we change their attitudes towards diet? How can we encourage people to exercise more? Well, there's been a sea change in European populations over the last 25 years in their attitudes towards these adverse lifestyle risk factors that have seen astonishing changes in people's behaviour patterns. So, for example, on the left-hand side, we see just over the last 10 years the changes in cigarette consumption amongst in the USA. 23% of people smoking in the year 2000, down to 15% in the year 2015. And if you put that back another 20 years, you'd see that perhaps in the 1950s or 60s, 50 to 60% of the population was smoking. It's now down to 15%. My children, aged 20 and 21, they wouldn't dream of smoking. It's socially unacceptable now. So these public health measures can work. They take a generation. But you've got to start the process with the vision of that long-term benefit. Identifying the high-risk people. Coronary heart disease doesn't develop overnight. You get warning signs that people are at high risk and overburdened. You can spot the high-risk people coming, and there are tools to helping us spot these, who is likely to develop disease and who is not likely to develop disease. There are a number of these tools available. For example, the classic one is the Framingham Risk Score. It's never been properly validated in South Asian populations, but it's better than nothing. And there are alternative risk functions such as Q-risk, the Indian Diabetes Risk Score, etc., etc. We have tools for predicting who is at high risk of disease. We need to be implementing them. Having identified high-risk people, what can we do to prevent them developing disease? We have effective treatments, both for prevention of diabetes and for prevention of cardiovascular disease. For prevention of diabetes, we have lifestyle intervention and metformin, relatively cheap interventions. And we have the statins, which are now off-patent, available at 2 rupees a day, readily accessible treatments. The statins all lower cholesterol levels effectively, and across the range of lipid levels achieve very profound reductions in cardiovascular risks, at least 30%. So, we know what the risk factors are, we know that protecting the public from them and educating the public is effective, we know how to identify high-risk people, we've got drugs that we know work and that are available to us. So now we need to get these into the healthcare system. And this has been one of the great success stories for particularly the UK, because over the last 15 years we've had comprehensive, government-driven, comprehensive strategies for dealing with cardiovascular and metabolic risk in the population. It started 17 years back with the so-called National Service Framework for Coronary Heart Disease, where the government set out 12 standards that all doctors in the UK were then obliged to follow. Screen, treat, look after the patients to these 12 standards. Now, more recently, they've implemented national health checks where every member of the community population should be coming for a health check every 5 years. And now because of the upsurge in diabetes, we now have a national diabetes prevention program, the first in the world. These are programs to learn from. Do they work? Yes, they work. The evidence is in the falling mortality rates, but also in these metrics such as the improvement in quality of care seen across the decade, and in terms of on the right-hand panel, we've got the increasing uptake of preventative therapies, statin therapies across age groups, across risk groups. So implementing national frameworks and then monitoring to ensure that people are delivering upon the frameworks can be successful. So here's me as an advocate now for a patient. This is how I think my patients want healthcare to be delivered. They want to deal with this huge burden of non-communicable disease, diabetes and cardiovascular disease. They want effective programs of prevention to be implemented. And this is how I implement my prevention programs. I don't do it personally. I have a team of people who do it for me. I look after a population of 100,000 people. And this is how I have a team of not nurses, not doctors, but community health workers who do it for me in London. And we systematically invite them up for cardiovascular risk assessments. So here is a 56-year-old man. He's invited to a checkup. He's known to have hypertension. He's a non-smoker but has a sedentary lifestyle. He has a comprehensive cardiovascular risk assessment. It's not, when I say comprehensive, it's nothing terribly clever. We measure his BMI, we measure his blood pressure, we measure a glucose, an HbA1c and a lipid profile. It takes 5-10 minutes, okay? It's not a big deal. And with that, we can then calculate his risk of getting cardiovascular disease with a standard calculator, and it's high, it's 18%. Armed with that, my community health worker can then give him lifestyle advice about diet, physical activity and weight, and he can write to his family doctor to say, please start metformin and statin because he's at high risk of diabetes and cardiovascular disease. And with that action, an impact that would cost as little as 1,500 rupees per person per year, I've helped prevent my individual developing type 2 diabetes. That's preventing him developing renal failure, visual loss, and cardiovascular disease in due course. I prevented him developing myocardial infarction, so preserving his heart function and preventing mortality. I've helped him maintain health, wealth, and productivity for his family, for his community, and for his country. That's a job well done. Now, there are challenges to implementation. The UK, we are in a luxurious position of having a national healthcare service. It's not so easy. You can't just simply be translated. Some of these processes are resource intensive. Is there the capacity to implement these things? Is it sustainable? Do people have access to these? We can't simply transfer this model to an Indian healthcare setting. But the opportunities are there, the knowledge is there, and we need to work with our colleagues in technology to make these approaches affordable, effective, scalable, sustainable, taking advantage of innovations in diagnostic technologies, innovations in production techniques to bring low-cost pharmaceuticals to the market, and also innovations taking advantage of digital technologies so that we can bring risk stratification, health promotion, and transformation of patients' trajectories to the populace on a large-scale basis. So these are my 6 ingredients to success, and I want to challenge the panel now to address how their technological environments, their technological knowledge can be brought to bear to address how we can use technology to educate, how we can use technology to identify high-risk people, how we can use technology to implement and monitor effective treatments. A quote from a great man that is not me: "Healthy citizens are the greatest asset any country can have." Winston Churchill, 1949. We have managed to reverse the tide of cardiovascular disease in the UK and in other Western economies. The challenge now is for the Indian healthcare system to live up to this. The roadmap has been set out for you. All you need to do now is implement it. Thank you for your attention.
Thank you, Professor Chambers. Leads us to the panel, and I have the pleasure of inviting a very eminent panel. If I can please be joined on stage, Mr. Ashok Kakkar, Co-Chair of FICCI Health Services and Senior Managing Director, Varian Medical Systems. Dr. Harsh Mahajan, Founder and Chief Radiologist, Mahajan Imaging. Mr. Joe Nicholas, Founder Director, Cancer Treatment Services International. Dr. Sanjeev Bagai, Vice Chairman and Director, Manipal Hospitals, Dwarka. Mr. Anjan Bose, Secretary General, Nat Health. And Ms. Zoya Brar, Co-Founder and Director, Core Diagnostics. I'm going to start with Dr. Sanjeev Bagai, because truly he's got people crying for him in his clinic. Dr. Brar, you're looking at artificial intelligence, you're looking at sensors and biosensors, you're looking at predictive analytics. All of them sound extremely promising. All of them sound absolutely exciting. For a technology enthusiast, this is the best thing that you can get to hear about. Tell us exactly, how is the patient benefiting? Is the patient benefiting? And I'm going to have an overarching question that's going to probably cover the entire all of this. And with technology, if I don't use the word cloud, something is going to be wrong with me, so I've used that word. But there is a greater cloud that happens when you start talking technology and healthcare. Are we doing this to increase costs, or are we doing this for increasing the efficiency of the care we provide? Or are we doing this for the speed to diagnosis? Or Is it a holy combination of all of them?
I thank. I requested for the question first to me, so because I have an emergency thereafter. So, if you really look at technology, it's not an expenditure; it's an investment. And if you look at technology overall, there's a very clear ROI which you can build. Just as a ballpark figures which are documented, they're published worldwide, you have a 50% better utilization of infrastructure, of bed utilization, of OT utilizations in a hospital or in the Indian, especially in the Indian healthcare system, which is overstressed and overburdened with patients. Medical errors are practically eliminated with digital technology. And when you look at the last published data of 2016 by WHO, medical errors in hospitals is the third most leading cause of death. And if you can prevent that, patients benefit. There is also a 30% odd decreased manpower which is required in the hospital, so therefore that much more benefit. But coming directly to the questions which our moderator has posed, the first one is artificial intelligence. I clearly feel that AI, including things like virtual reality and augmented thinking, is going to change the way we see disease. It's going to change the way we look at cure, and patients are going to look at their own health profiles very differently. Just as a ballpark figure, artificial intelligence, be it in laboratory, be it in radiology, be it in clinical diagnosis, looking at Cochrane trials for treatment modalities and protocols, also establishing established protocols for investigative profiles of different patients. So, for example, you can get approximately in about 20 to 30 odd seconds, approximately 2 million odd articles which are filtered through, refined, which are individualized specifically for that patient of that age, of that sex, of that generic group, of that ethnic background with those comorbid conditions, and it can fine-tune and tell you what the best treatment modality for that would be. It would help you pick up diagnosis which routinely will not come to a clinician's mind. It will help you to reach simpler diagnosis quicker. It will save time, it will save energy, and give better clinical results to patients. Especially in the surgical field, these are technologies which actually aid a patient. The reason is you can virtually, in terms of virtual reality, navigate through a patient before surgery one day before and take a dry run, so to say. The other thing which is going to change healthcare, which is already changing in various parts of the world overseas, in Western developed countries, is sensors. These can be ingested sensors, they can be wearable devices, much like a wristwatch. They can be sensors which are tattooed on. These are sensors which are actually like a root canal being implanted in the teeth. So what do? In real-time data, they capture the temperature, the pulse, the heart rate, the blood pressure, the saturation of a patient, and it comes to a control center as a command center in the hospital. So the command center and the patient is actually alerted even for the slightest change. Let's say a post-operative 99 to 100 degree spike of fever. It preempts you to tell you, is the patient susceptible towards post-op infection. It can pick up arrhythmias, it can pick up disorders of Parkinsonism, it can pick up preemptive falls when a patient's gait is slightly faulty. So I think sensors also calculate the amount of water which you've had. It will tell you the amount of salt intake which you've had. It will restrict you, it will alert you, and it alerts the healthcare professional in a hospital. So I think these are the two very, very broad technological advances which are already coming into India, which are very well established overseas. And with this, what you actually do is to generate a host of data, a data for the patient and a data for the hospital. The data for the patient is much like having without lead pocket ECG. So this exactly, you just have it in your pocket. You can transfer the data through Wi-Fi to the hospital. It can actually record and halter without you going through a cumbersome procedure. And predictive analysis, that means this data which is calculated for that patient, whether the patient is at home or an inpatient in the hospital, will actually give you a near 95% sensitive and specific predictive score. So say, for example, it'll pick up a patient who's 1 kg as a preterm, running a platelets of 1 lakh with a CBC count which is 5,000, which is low. It'll tell you the hemoglobin, which is 10, and it'll tell you the next 2 or 3 days what the predictive analysis of the drop of these values is. So this gives you a great impetus as a red flag alert as to what to watch for, which patient has a potential to crash or which patient is going to behave little differently tomorrow. So say, for example, most people would take, I'm sorry, I'm using clinical terminologies, as a serum creatinine of 0.8 to be normal. But in a smaller baby, 0.8 is actually an alert for a child which is susceptible to go into acute kidney injury or complete renal shutdown in the next 48 hours. So it tells you a day ahead of time. It tells you 48 hours before time as what is to be happening with the patient so that the clinicians are better alerted. So I think technology is the way forward. It saves money. It's better for patient. From operational excellence point of view, it gives a better return on investment. It's a better utilization of infrastructure and manpower. From a patient point of view, it gives you a better patient experience. It makes a patient a part of the decision-making protocol. It makes a part of the decision-making cycle because the patient is directly involved in seeing what is happening. And most importantly, as far as the doctor is concerned, it gives better clinical outcomes. We talk of evidence-based medicine. Here it is. Thank you.
Thank you, Doctor. I'll probably move now to Dr. Mahajan. And we've got imaging technology that's been in use in the healthcare and the medical field for the longest time. Sometimes I wonder, doctors it's always told that doctors are resistant to technology, and I wonder why such comments are made, because doctors are the ones who actually grew the entire medical imaging technology to where it is today. Dr. Mahajan, you got fantastic institutes on imaging. Imaging is now used in almost every specialty, subspecialty of the field of medicine. There are a couple of things when it comes to imaging and the medical technology that's being used. One, is the patient really seeing the benefit of this? And we heard that at the IMRB research. Are we explaining it well to the patient? We also hear in terms of the fear that some of imaging technology and what's being used, and you hear so many articles, you use radiation and cancer will not be cured. So it immediately puts in a massive fear psychosis. And the future of medical imaging that really gets to speed to diagnosis. Dr. Mahajan, take us through that.
That's a lot of questions, some comments. One, I'll take the fear factor of these radiation devices first. I think it's real, but it's also overhyped. There's truth to both. If used indiscriminately, it can harm. But what has happened in the last 10-15 years, because of this fear, it has led the equipment manufacturers to actually create innovative new machines which have lowered the radiation dose given. As a cardiologist, Professor Chambers would know about the CT coronary angiography, which we started doing in this country in the year 2003-2004. The radiation was anywhere between 20 to 25 millisieverts, millisieverts being a measure of radiation, and I'll tell you where to actually peg it. Over these years, because of the hype, that radiation dose now for an average 80-90 kilo person is down to less than 3 millisieverts. And 3 millisieverts, if I were to say, is the radiation you get when you fly from New Delhi to New York and fly back. So that's how low it has come. And we can even do it sub 1 millisievert. So radiation, if used prudently, one should not fear it. It's not going to create cancer, and there is actually where things went wrong is where people develop cancers, and not as a routine. But that did bring focus onto this aspect, and both as radiologists and as medical equipment manufacturers, I think that focus has helped. But don't fear it. Second, I think we need to look at, Dr. Bagai just talked about, the highest end of where medical technology is and how it's being used, but that may be used in a minuscule minority of patients at the present point of time, and as it gets cheaper with more and more people using it, with it becoming more prevalent, it'll get cheaper. But how do we reach the primary care level service providers, and how does it help in the tertiary or the secondary setting? At the primary level, in this country itself, even though it's different states who've done it, but through discussion with radiologists, the government has set up a program. Previously, at the primary healthcare or even at the level above that, X-rays were done and it was up to the doctor or the technician sitting there to report. But through digital technology which is available, we have satellites up in the air, which CSIR is very willing, to provide to the government. Today there are centralized centers of teleradiology which are reporting on each and every one of these X-rays done remotely, the report going within specified time frames of 2 hours, 4 hours, as the case may be. So even at the primary care level, and this has happened now in multiple states, ruled by the ruling party or the others, and it is working. So these X-rays are not going unreported anymore. They are being reported, and they are actually helping in defining therapy even at that peripheral level. At the tertiary level, with the availability of PACS, picture archival systems, which even till about 7-8 years ago would cost about $1 million to put in place. Today, when someone says it'll cost you ₹1,00,000, we look at him and say, hey, why are you overcharging? So that has brought digital technology into, you're able to store all your data, you're able to retrieve your data at costs which are very, very affordable. And with that has come artificial intelligence. In fact, today we get, because we've had these systems in place for about 10 years, we get requests from different parts of the world. They need data of patients who have disease to be able to put those in and develop algorithms for artificial intelligence, and already to differentiate whether a chest X-ray, and this is work out of Israel, work out of Stanford, and we are working with both of them, to differentiate whether it's a normal chest X-ray or abnormal chest X-ray, you need a radiologist. Once these algorithms become robust, and they're nearly there, maybe 70% of chest X-rays which are normal, a radiologist may not even need to look at that and be able to spend more time in diagnosing pathology rather than in spending similar kind of time on normal. So artificial intelligence, and I think within the next 5 to 7 years, even at the highest end of reporting MRIs or CT scans or PET CTs, I think artificial intelligence will become very, very relevant, robust, and that's where even the shortage of radiology personnel that you have in our field globally, that will also be addressed. So these technologies, as I like to say, are not just technologies for technology's sake. They are helping in diagnose better, they are helping in access, and they are also going to be helping in developing algorithms which will change the way we diagnose disease, and ultimately better, more targeted diagnosis will lead to better treatment outcomes.
Thank you, doctor. I'm not sure you got the vibe there. So here is the patient who's panicking, who's posed a series of questions at the doctor, and the doctor very politely answered what it means to all of us. Thank you, doctor. That was... So with the doctor using technology, and both the doctors seem to be very, very optimistic about what technology can do, and they said this is the way to go and this is going to get the best care outcomes. But then we have the virtual doctor who's always present with all of us, and that's Dr. Google or Dr. Watson. And if any of us have not consulted Dr. Google or Dr. Watson, you are considered socially illiterate. That means that your set of questions is going to be to Zoya. Zoya, you had a background with Google, the organization that loves to come in and disrupt almost everything that we do normally. I don't know, they are abnormal. Zoya, you got a fantastic background in diagnostics. There are a zillion apps on the App Store. Electronic medical records has been spoken of across the globe. In fairness, is there adoption? Are we really, their apps are there, they look good to have, they look good to consult, but where is the adoption? Are we really serious about, is the patient serious about using apps, or is apps just a style factor or a comfort factor? Should we really go around investing in apps? Is it going to make a difference, or you just go back to the traditional medicine, we go to the doctors and just get ourselves cured?
Thank you. So I'm definitely the least qualified on this panel to give any opinion, but since it's about apps, I guess my age is on my side. I think the question is not really should we be investing in apps, but what should we be doing about all the apps that are already there and all the technology that's already there. Like you said, EMRs have been there for many years. A lot of apps are already there, a lot of technology is already there. The question is, why is it not getting adopted? So forget people outside the room. If you just ask yourselves, how many of us are really using a health app? Would you just show of hands? How many people are constantly on a health app? I saw one hand go up there. Okay.
Consider the Apple.
No. Okay, fine. Yes. That's 2, 3. How many people are 4? Okay. How many people are on WhatsApp?
All.
Right? Facebook? I made my point. So 2 things that change behavior. One, when you look at a banking app like Paytm or HDFC or any of these guys, which we all kind of use, these apps have trust. We trust those systems. We trust that when we put money in the bank will not eat it up, right? So we'll trust their app too. If we look inside, we ourselves don't trust healthcare. We are healthcare, right? We don't trust it. I don't trust it. So question is, how do we expect patients to use an app when they don't trust our system? And second, I think the factor that prevents people from using and really getting into the technology is that when we are creating technology in healthcare, we don't try and embed it in the daily life of the patient. So we create a EMR and then think about the patient. At the real end, we first think about the doctor, we first think about the hospital, how will it integrate with our appointment system, how will it integrate with X, Y, Z. We don't think about how will the patient use this application. And even if we do, we don't embed it with something that they're used to. So I think both of those factors prevent adoption. We have already, as an industry, created too much clutter. We've created systems that don't talk to each other. That there isn't enough interoperability amongst those systems, and which essentially begs the question that we don't really need more. We need to fix the problems that prevent what we already have from getting used. So.
Thank you, Zoya. So we need to fix the problem, but then the moment we think of fixing problems, our direct thoughts go into what's going on in the West. Jo, consumerism in the United States is well known. The legal system governing healthcare, sometimes, I've heard comments that doctors in the US practice with a law book in the hand and they've given up the stethoscope. Well, what's the link between the use of technology, the right use of technology, if I can say the right prescription of technology, and consumerism. And if you can compare your experience between US and what you're doing now in India, tell us where that's going.
When I was first asked, when I was first asked to be on this panel, I thought a lot about it because the differences between the Indian consumer for healthcare and the U.S. consumer for healthcare are daunting. We talk about technology. Indian patients use the internet, maybe not so much apps, but the internet to compare services because the price that they're paying for these services come out of their own pocket by and large. I don't know what I pay my doctor in the US, right? I know what I pay my insurance company monthly, but I really don't know that for my wife when we had a baby that it cost us $40,000 for her cesarean and she was in the hospital for a week, right? I know that I pay my $300 a month for insurance. Indian consumers, on the other hand, are constantly, at least in the oncology business, the business that I'm in, are comparing hospital costs, doctor costs, and the bottom line. And so from a consumerism point of view, that's different. The way they get that information is obviously by word of mouth, but they're used to compare hospitals and doctors, at least again in oncology in India, is to use the computer and use the internet to do such. And that's I think the biggest difference between consumerism in the US versus the Indian consumer.
Joe, thank you. And I'll probably next move to Ashok. Ashok Varian is a huge medical oncology equipments organization. You're supplying equipments to probably deal with the most difficult of diagnosis that can happen. You're investing a lot into research to make these happen. These equipments are costly. These equipments are not going to be easy for hospitals to afford. But despite all of this, these equipments really help in the diagnosis. How do you balance, from a hospital's perspective, the right technology to use? How do you justify the cost around this and the outcomes when you look at it from the patient's perspective? And how do we explain that actually technology is doing the right thing by being employed in the service of the health delivery?
Thanks, Arvind. Before I answer that, I just wanted to make a very quick comment on technology in general, and especially in context of healthcare. Technology use at the point of care is well known. Whether we talk about CT MRIs that Dr. Harsh uses or the radiation equipment employed by Joe in his cancer centers. So that's well established, the efficacy of these equipments and so on. The next level is what Zoya was talking about, is the evolved customer, and the way even the survey talked about use of technology by consumers today and the patients today, and they're getting more knowledgeable. To my mind, the third level of technology use in healthcare, which needs to happen, is around how do we empower the patient and how do we get them in the decision-making process. I was listening to the afternoon discussions where an increased need was felt that we need to talk to patients more, engage them, and more so, mind you, we are talking about cancer care, we're talking about NCDs. The problem with NCDs is it's not a transaction. The patient has to live with that disease over several months or years, and the care providers have to manage that along with the patient over a prolonged period of time. The issue is today, the patient is not at the center of the universe when it comes to healthcare. It's the hospital. And the hospitals treat it as a transaction. The patient comes, surgery done, radiation done, and it's over and gone till the time the next patient comes in or the same patient comes in. So how do we get patient in the center stage? How do we ensure that patient is empowered to the extent that he participates in the decision making? and there is a constant dialogue. Talking about appropriate technology, I think today a lot of work that we as Varian are doing, and I know there are other organizations which are doing, to ensure that there are platforms available where this dialogue happens between the care providers, and there's not one single doctor anymore. To handle cancer patients, we are talking about multiple care providers. You know, there is a surgeon, there is a medical oncologist, radiation oncologist, counselor, and so on and so forth. So how do patients over a period of time, after they are out of the hospital, when they're at home, when they have questions, when they have complications, when they have side effects, are able to engage with their care providers without actually going to the hospital? Because if they go to the hospital, they have to wait 3 hours. And then there are not enough doctors who can spend time with them. So, but if there are platforms available where a patient can, say, post a question and gets answer within 24 hours in a detailed manner, there is also a repository of the entire information which is available. I'm simplifying the platform or the portal to an extent, but the idea which I was trying to drive at was that there has to be a constant engagement, and there technology can play a big role. Because you know the way the whole protocol and the pathway evolves, especially with NCDs, is not limited to what happens in the hospital itself, but over a period of time which can be very long. Yeah.
Thank you, Ashok. My last panelist, and for a right reason last but definitely not the least. Anjan, you had an illustrious career in the entire healthcare field. You've been with the medical imaging companies, you've been at top decision-making spots, and now you are the Secretary General of the largest hospital consortium in the country. In a way, are you swallowing the bitter pill that you created? What are you demanding as a patient? What is the right that you're demanding? What is the return on investment that you're asking, and what are you asking as outcomes?
Thank you, Arvind. When Varun contacted me and asked me to do this session as a patient, I thought he was trapping me. Because for someone who has come from medtech for decades into healthcare and also some other roles, that, as you mentioned, one correction by the way, the organization I represent is multi-sector. So it's not hospital only, but medtech, diagnostics and others. So very briefly at this time of the day, Albert Einstein once said the definition of insanity is, I'll just give it a little bit of twist, insanity is to keep doing the same thing again and again and expecting different results. As a patient, I often feel that there are a lot of things that are done not in the spirit of continuous improvement, but sort of, in a mechanical way for too long a period before actually reviewing and correcting something that can be corrected. As a result, everything goes for a toss, including the return on investment that as a patient I'll expect. That's one. Secondly, I'll steal from esteemed Dr. Jairam's very crisp 4 points that he gave in an earlier panel. As a patient, I'm the last point in a supply chain in a sector. I've always found it difficult. Shobha knows when I used to work with her in FICCI. I've always found it difficult to say or write healthcare as an industry, even today. And you will find my colleagues are sitting there. I like to mention healthcare as a sector because the uniqueness of healthcare as a business or industry is that at the end of a supply chain, you don't have a car or an inanimate object like a computer or a camera or a cell phone. You have an agonized patient, often in pain, surrounded by very worried friends and relatives. And that end point of supply chain is usually, as you said, in hospital, but today also in home, because home care is growing very fast. That's a very important angle. So as a patient, I would expect, the caregiver, whether it's a home care company or a hospital company, to be ethical, to be process-oriented, to have very good communication with the patient, which is a very big need area in India, because that God factor is still continuing. And often patients are worried even if they are getting treated properly because they are just not understanding what is being done. So ethics, process orientation, communication, and this regular quality audits, which sort of goes in the direction of what Einstein said, that it's if you keep doing the same thing, Joe, again and again, your cancer services possibly will not go to the next level. So in essence, I think these are the things that as patient I would like to expect from whosoever is delivering the care to me. And I think technology is just a part of that. Okay, my message to the technologists will be that technologists can tend to feel that they are away from the patient. They are selling it as a vendor to the caregiver. I beg to differ. I think I come from two great technology organizations where it was grilled into our system that, patient centricity. I saw that in Varun's organization today, and I loved it. Because at the end of the day, all the stakeholders in the supply chain have a responsibility to make it easier for the patient, to make it a good return on investment for the patient. I'll stop here. It's 6:10, and I think we have had a long day. So this is from a patient's perspective that I expect.
Thank you, Anjan. Professor Chambers, I definitely hope we've done justice. And the challenge that you put in front of us was reasonably addressed. Clearly, technology is looking at a very optimistic way. I feel very comfortable sitting where I'm sitting because I've got the doctors who say technology is the right thing to do. Technology is the right investment to make. I've got the industry experts who tell me that technology is patient-centric. The CIO's job is pretty easy these days. You've got all the right people doing all the right stuff for you, so just sit in between them and say it'll happen. It looks very optimistic that technology is the right thing to use. It's measured that we need to ensure this is factored around the patient being the center of our universe. Because the outcomes are going to be measured by what really the patient wants, and at the same time not only focusing on the consumerism of what the patient wants, but the right medical action that only the medical experts know how to provide, where to provide, when to provide, the right quantum of it, the right medication given at the right time to the right person. Technology is the medicine here that we are talking about, and technology is the optimistic medicine that the industry can use to bridge the gap between the supply and the demand. Thank you very much, ladies and gentlemen, for being a patient audience. Namaste and have a wonderful evening.